Well, good afternoon, everyone. My name is Jennifer Salerno, and I'm the Research Associate for the McMaster Institute for Research on Aging, Collaborative for Health and Aging. Thank you for taking the time to join us. We have a few tips for getting the most out of the webinar today. If you have not already switched your view in Zoom to speaker view, we encourage you to do so. On your Zoom screen in the top right-hand corner, you should see an icon. If the wording under the icon says gallery view, click on the icon once, and this should change it to speaker view. If for some reason you are not muted upon entry, we ask that you mute yourself to eliminate any background noise or feedback during the presentation. I would also like to alert you to the chat icon at the bottom of the Zoom screen. If a question or comment occurs to you during the presentation portion of the webinar, we ask that you please type the question or comment in the chat box, and we will review these during the question and answer portion of the webinar. And please note that this webinar is being recorded. So I'd like to begin this webinar by recognizing and acknowledging that McMaster University is located on the traditional territories of the Mississauga and the Haudenosaunee Nations, and with the lands protected by the Dish with One Spoon Agreement. It is my pleasure to introduce this first webinar in our series, and we'll be in touch by email to share the topics of our future webinar in this series with you. Today's webinar will be given by Drs. Brenda Vrkljan and Marla Beauchamp. Brenda is a professor of occupational therapy, and Marla an assistant professor of physical therapy, and are both in McMaster's School of Rehabilitation Science and members of MIRA and members of the MIRA Collaborative for Health and Aging. They both lead independent and collaborative research programs focused on mobility and aging. Marla holds a Tier 2 Canada Research Chair in Mobility, Aging, and Chronic Disease. And this afternoon, they will be talking about the experience of pivoting a large-scale project during the COVID pandemic, and we'll share some reflections on that experience. So it's my pleasure to now turn to our speakers of the webinar.
Thank you, Jennifer, for that kind introduction. And it's great staff like Jennifer and the other folks at MIRA that make these events possible. So we certainly thank MIRA and the MIRA Collaborative for their assistance in this webinar. And we look forward to other webinars as part of that series. So yes, I'm Brenda Vrkljan, and I'm pleased to be here alongside my colleague, Dr. Marla Beauchamp, to discuss early lessons from some of the steps that we've taken to pivot our large-scale study on aging and mobility. So while Marla and I have the pleasure of presenting to you today, our team is comprised of multiple disciplines, staff, trainees at McMaster and beyond, as well as our older adults and other partners in our community. So just before we share our agenda for today's meeting, I will say that pre-pandemic, yes, that's a word, we were rocking and rolling and getting our research platform underway. So these pictures are from before social distancing came into effect. And really that was then, and this is now. Well, sort of now. That's a holiday pic of our team dressed in festive red just before we had a break this past December. So today we'll be talking not only about our research team meetings pivoting online, but also walking through some of the early lessons that we've learned during this pivot. So first we'll begin with a brief overview of our large scale project.
Okay, so to give you a little bit of background on our project, we actually, back in 2019, or maybe it's 2018 now, I'm getting dates confused, Brenda and I participated along with other researchers in MIRA's big experiment. So bringing a group of researchers together with from different faculties and different backgrounds, and trying to see if we could co-design our way into coming up with a research project that would tackle some exciting new novel aspect of aging research, but also that would be important from the perspective of older adults. And so we came up with the McMaster Monitoring My Mobility Research Program, or MACM3, and we were successful in receiving over $2.1 million in funding over 5 years from MIRA, AgeWell, and also the McMaster University Provost. So the goal of MACM3 is to use advanced technologies and statistical approaches to improve how we identify and assess mobility problems in their earliest stages in older adults. And to do this, we conceptualized sort of a 5-year research program that has a number of different sub-projects and sub-aims that we've been working on over the past couple of years. But the project actually culminates in the development of a mobility self-monitoring tool that older adults and their caregivers can use to help manage their mobility as a critical aspect of their health. And the largest component of our research program, and I'll talk more about that in a minute, is a prospective cohort study where we're actually tracking mobility in the home and in the community in our older adult participants. And I just wanted to make a note to say that this project, when we came up with this project, it was with the input of our stakeholder advisory groups, which includes older adults and community organizations. So this was the original design of MAC-M3, the prospective cohort study component, which will be the main focus of today. So it's a 2-year study. We wanted to enroll 2,000 older adults between the age of 65 and 80 years old with differing levels of mobility limitations. And originally, the study was going to have in-person visits at baseline 1 year and 2 years. And then every 3 months throughout the study, we were going to use a smartwatch that had both your sort of standard accelerometry to measure things like physical activity, but also would have a GPS sensor so that we could measure, that we could actually track how often people leave the house, locations of interest, things like that. So looking at mobility, not just from the perspective of traditional things like step count or sedentary time, but also considering this out-of-home mobility piece, which we thought was really, really key. And so, what was I going to say? And so the point of this is that doing this project was really poised to be one of the biggest cohort studies really centered on mobility from an interdisciplinary and comprehensive lens.
And of course, with any involved study and large scale study like that, it becomes really important to have a strong organizational framework and platform. So our structure included, as we've mentioned a few times, an older adult advisory group, as well as community, private, and not-for-profit partners to help advise us on various aspects of the project. Our plan was also to have community sites that would pop up, so to speak, in the community in existing and accessible places to promote older adults' participation in the project through our data collection in-person sites that would be in their neighborhoods at places like the Hamilton Public Library and senior centers and other areas, again, aiming to promote the accessibility of our project. And just when we were ready to roll, COVID-19 entered all of our professional and personal lives. In fact, it was, if we go back to this day, Dr. Ina Wobin, the managing director of MIRA, Marla, and myself were actually supposed to travel to Toronto to meet with some of our partners from the UK, one of which we noticed is on the line, Dr. Carol Holland, who had traveled all the way from the UK to be with us in Toronto. And the irony is that we did not get on the GO train that day because, in fact, the university and Ontario was in the process of shutting down. So we joined by web conference that day, and that was, who knew that would be the beginning of many web conferences to come. So this pic was actually texted by my mom as the grocery store lineups began. You can see that the socially distanced marks that are now on the floor didn't exist then. And I think you can also spot some rolls of toilet paper in the grocery carts. Of course, we know what happened next in March, and here in Ontario and across Canada, everything came to a halt. The following week, after this picture was taken, McMaster and other universities stopped all in-person human research with the exception of specially approved trials. And as you know, many restrictions continue to be in place, and rightly so, for research involving face-to-face contact with older adults and other high-risk populations. So at the end of March, we started planning changes to our protocol. So as we pivoted our project, we were not alone in considering the impact of COVID-19 on the health and mobility of our aging population here in Canada and beyond. So this article was published in the Canadian Journal on Aging, and it noted the importance of interdisciplinary and collaborative approaches needed to examine the impact of COVID-19, which of course resonated with our interdisciplinary research team. But the question remained, how might we ensure our research continued without compromising the health of our team, our participants, our partners, while still holding true to the intended aims of our project? So in fact, as we began to move forward, we reflected on the changes that we started to, or had started to undertake at the end of March and into the beginning of April, which we've captured in this submitted publication. And not surprisingly, elements from the manuscript inform our presentation today. So perhaps some of what we share with you today will validate some of the changes you and your team have made or are considering in terms of adapting your research programs to promote participation of older adults. So one of the first things we found ourselves discussing and debating was this notion of non-pandemic and pandemic research.
Right. And so this was sort of a bit of a heated debate at the time. We noticed that a lot of ethics institutions and funders, as well as other researchers, really began dichotomizing research in this way, as pandemic or not, COVID or not. And the more that we thought about how we needed to pivot our MAC-M3 research program, the more we realized that actually dichotomizing research in this way is not particularly helpful, because we've all been forever changed by COVID-19, including our participants, and our research needs to adapt to consider this new context. So what we propose in this article is that really all research moving forward is conducted right now needs to be considered in light of the pandemic. And when we think about how we wanted to visualize this sort of way of thinking, we came up with, Brenda, can you go to the next slide? We came up with this model that illustrates sort of our thinking about the pandemic. So no matter where your research is in this continuum, as either pre-COVID-19, during COVID-19, or post, or hopefully soon, post-COVID-19, there are many components of the research process that might be impacted by the pandemic that really does need to be considered in this new context. So for example, if data collection for a study occurred just prior to COVID-19, then the potential application of the findings will then need to be interpreted in light of the current context, right? So we're living in a very different world than we were living in before. Similarly, even studies with older adults that are not directly focused on COVID-19 or on the virus itself, we need to consider how the research participants may be affected by the ongoing pandemic and the public health restrictions. And so, for example, we know that older adults are less physically active, and we'll show you some data in a little bit about that. Have some increased anxiety, have decreased access and use of healthcare right now. So all of these things have methodological implications for recruitment and for data collection. So by using a continuum approach, we can better understand the implications of the pandemic for the different aspects of our research.
Yeah, so when considering where our research program fell on that continuum and the impact of COVID-19 on our target population, we started to think about the methods that we had planned, and our team needed to take a major step back last March and sort of redesign and reconsider our approach in certain ways in terms of data collection, including how we engage with our community and our community partners. So in fact, everywhere we looked in terms of our research plan and our design, there were just this litany of challenges that required our attention. But a plan started to slowly emerge, which we attribute in part to three main strategies undertaken, which enabled us to pivot our study platform and begin to proceed slowly but surely amidst the COVID-19 pandemic. So one of our first steps was to engage with older adults virtually and through informal conversations that explored the impact of the pandemic on their daily lives. And these early conversations were so important, and they were with a convenience sample of older adults, as I mentioned, but they were critical and instructive as to the ways in which we could understand how the pandemic was perhaps impacting their health and mobility. And so from these conversations, there was an interdisciplinary subgroup of our larger team, as well as recruiting a few other members with expertise in certain areas. And we'll talk about that in the next, on number 2, in terms of, recruiting people with expertise in nutrition and other areas. But really having these conversations with our older adult partners in the community and having them join our team became really important. And in fact, we developed a survey in order to try to understand the experience of those living in the community. So we in fact enlisted the help of Mary Mills, who's pictured here during a socially distanced visit this past summer, who helped us and proved critical really to helping us understand, what it was like to receive the survey, if there were any issues that we had to be thinking about in terms of administering the survey and the way that we were doing it. And in fact, it was even some of those early conversations with Mary that helped us also add interviews to our survey. So it's now a more mixed methods approach to understand that sort of lived experience of older Canadians in quarantine. So Mary has been able to join us today, which is great. And I'm just going to ask Mary to speak a little bit about her experience as being involved in research during the pandemic. Mary.
Yes, of course. Being involved in this research has been not only enlightening, but it's given me something to look forward to, which isn't much these days when you're home alone in a pandemic and anxious and getting more anxious because of the lack of vaccines coming. And but being involved in this research has been so interesting because McMaster does such a great job in reaching out to people and has just been great for me. I've been able through McMaster to keep up with their webinars. I actually also joined PACE, which has all these exercises for people to do every day. And I just really would like if McMaster could become more involved in the community and people would know about what there is available through McMaster, because it's very intimidating for seniors to go and difficult to go to McMaster, but we can go to libraries or senior centers and be part of your community.
Yeah, so one of the things we talked to Mary about, thank you, Mary, for sharing your insights and for the privilege of letting us know how challenging the pandemic has been for you, as well as some of the other older people that you know. But this idea of how if you were to receive a phone call, for example, when you're administering a survey, and in fact, it's a kind of a cold call, right? Because you don't, nobody, in terms of the way we recruited our participants, was that we were reaching out randomly through a random sample of phone numbers to try to create these partnerships. So Mary let us know certain ways we could script it to try to make those the early few sentences in that phone call to help build those bridges, which are so important. So thanks again, Mary, and we'll continue on here in terms of the presentation. So Mary is Marla now is going to tell you a little bit more about the survey that we undertook.
Great. So thanks so much, Mary, for helping us with this survey. So this is called the Impact Hamilton Study, and it's led by a team of us. As Brenda said, we put together a team in a short amount of time to try and really understand the impact of COVID-19 and all the different public health restrictions. What would that impact be for older adults? And particularly, we were interested in older adults that were living in the Greater Hamilton area, as this was one of our main recruitment sites for MAC-M3. So we were primarily interested in how the impact of the pandemic on mobility and participation. But we also had some secondary objectives looking at mental health outcomes, nutrition, and musculoskeletal health and pain. And so we started a longitudinal telesurvey with follow-ups every 3 months for a year. And we started this in May during the first, we were just kind of in the middle of that first wave of the pandemic. And we're just doing our 9-month, we just started our 9-month follow-ups right now. As Brenda said, we recruited a random sample of older adults living in Hamilton. And so we'll share with you some early results from this study. So these are just our baseline findings. We ended up recruiting 272 people who had an average age of 78 years, and we had a nice range of ages 65 to 101 years old in our study. And so these are just some findings that we thought were interesting and have informed us in terms of how some changes we've made to MAC-M3, so we thought we'd highlight them here. So 32% of our sample reported less community participation. And when they had to list their top affected areas, those were visiting family, spending time with grandchildren, and their social lives. A really striking number is almost half of our sample were noted that they were less physically active than before the pandemic. And then almost a third of people had mobility scores that we would actually rate as being consistent with what we would consider to have extreme mobility limitations. So there's a significant number of people in the community that are really mobility limited. In terms of mental health, 35% reported loneliness, and 17% actually had very high levels of distress based on a standardized scale called the Impact of Events scale. And so even though that's still a non-trivial proportion of people that are experiencing quite significant mental health repercussions. So as Brenda said, conversations with Mary and looking at these early results also has helped us design a qualitative component to our survey, where we're doing interviews to look at the lived experience of participants with high and low levels of distress and factors that might be influencing this. And so these, considering some of these findings, we've been able to make some changes. We've had to make some changes to MAC-M3, to the design. So first of all, people that, if older adults are leaving their homes less often, a 7-day interval where we, if we use smartwatches just for 7 days, we might miss their outings. We might miss an outing to the grocery store, and people were reporting that they were leaving quite a bit less frequently. So we've changed our wear intervals for our smartwatches to 10 days instead of 7 days based on these results. The other thing that we've done is we've really augmented our mental health measures that we're collecting in MAC-M3, and we're also going to track that over time. And so looking at these results now, looking at the results at 3, 6, 9, and 12 months will be important also for us as we move forward with MAC-M3. But the other really important thing about impact is that it's also become a pre-recruited participant sample for us. And what that means is we did ask participants if they'd be interested in doing other research with us. And because now we have information on their mobility levels before the pandemic and during the pandemic, this will really help us understand how baseline might have changed for our participants when we go and begin our larger cohort study.
So given the complexities of the area of study, right, in terms of understanding people's mobility, their participation, and their health, this just adds, there's just multifaceted ways in which COVID-19 has affected people at both an individual and population levels. So we do consider ourselves fortunate that we were participating in McMaster, the MIRA's big experiment in terms of interdisciplinary team. But because there, as mentioned, there are advantages to having multiple perspectives around the table to be able to problem solve some of the issues that we were encountering. But simply having different perspectives around the table does not necessarily mean that collaboration ensues and discoveries abound. And I will say that as we went to look at, for some work that's been done on the notion of interdisciplinary research teams, we came across a special issue that was in Nature News in 2015. And what we found is that many of the principles that they talked about in that issue still stand in terms of how our team has been able to function and pivot in the face of COVID-19 and the pandemic. The issue is that oftentimes interdisciplinary approaches are poorly rewarded when we think about traditional academic boundaries, academic boundaries in terms of, being recognized. Sometimes it takes longer for publications to emerge. It can take a little bit longer for certain aspects to be finalized or to reach decisions and those kind of things. But in the end, as we read in that special issue and in the other articles that appear, there is a payoff. And so we found that, the basic principle for catalyzing collaborations, again, as I said, still hold true during a pandemic. So for example, as Marla mentioned, we needed a wearable device to be able to track the mobility of our participants and figuring out ways that could be deployed in an environment where we were dependent on remote interaction with our participants. So that ended up being a really highly collaborative exercise. So we needed engineering and geography, not surprisingly, to work together on the delivery, the setup, the calibration of the wearable device. We needed faculty members like Dr. Paula Gardner from Humanities, who's an expert in technology and the acceptance and usability of technology with older people, as well as, from our own school in terms of rehabilitation science, thinking about the translational impact of our findings on function and everyday health. So we're pleased to say that pilot testing is underway, and thanks to those on the line who've helped us already walk through a three-day pilot testing of our wearable. And again, we're trying to validate that, and Marla's going to talk a little bit more about that. So we continue to seek input from external researchers on our team. So for example, MIRA has an international advisory stakeholder committee, and we were able to present some of our pivots to them this summer. And again, the notion of mental health and the potential consequences of the pandemic on mobility came up there as well. And that's why we have added measures to our cohort to be able to track that going forward. So the idea of having different disciplines is really important. To have them at the table and to continue to do that. Of course, having institutional support from MIRA and the Provost Office is also very, very important, and that was highlighted in a series of Nature News articles. So finally, one of the major things was really from the outset of our project to recognize that research conducted on older adults often has involved people who are white, middle, and upper class backgrounds. So one of our foci was to promote the inclusivity of our research and make it accessible within the community. And our plan had been to use the notion of pop-up sites at places like the library to meet with our participants face-to-face. And of course, not surprisingly, we had to change that with the COVID-19 disruption. So we're still exploring ways, working with our Hamilton Public Library, as well as our colleagues in the Faculty of Social Science, who are establishing some of those relationships. And we're really pleased to be working with them to understand how can we still leverage the brands, that's what I'll call them. The library has a brand, but as Mary said, it can be quite intimidating for some people when they hear that the university is involved. Whereas if the library contacts impacts them, perhaps that's a place that's more accessible. Same with the YMCA and YWCA and other areas that we'll explore. So all of that to say that we're working with our community partners to develop that. So an example right now would be perhaps that, to be able to measure people's mobility in their home, they might get a package like this that has a laptop and our mobility tracking device. And then our older adults are able to connect with our trainees, with our researchers from their home. So in some ways, the university isn't just coming to the library now, the university is coming to them in their place where they live. So trying to think about that, of course, there's lots of logistics involved when we want to assess people's mobility remotely and ensure that that's done safely. So we are, again, trialing this approach, and Marla's going to tell you a little bit more about the validation involved.
Great. So, as Brenda said, we've been piloting not only, how do we get the wearable watch out to people and set up and all of that, but because our study is centered on mobility, like our entire focus of our study is on measuring mobility from all these different perspectives, we really, if we have to move away from in-person to remote assessment, we need to make sure that the measures that we're using are reliable and valid. And so what we've done, and I'm sorry, I should have put the names of the people involved, but Initiate X is basically a sub-study in a CIHR funded cohort on fall risk, where we were able to sort of put in some performance-based measures of mobility that we think might be suitable for completely remote and virtual assessment. And so people in the field of mobility might recognize some of these tests. So we're testing the timed up and go, gait speed, and the chair stand, and a few different versions of those tests. And so, what we're doing is actually delivering this virtual toolkit that has a tablet with preloaded internet and Zoom, so that participants don't need to have internet access or be tech savvy at all to be able to just turn it on. And we have very user-friendly kind of stickers, press here, and then they do this assessment session with a research staff, and they do this live. And so we're doing this in a sample of 120 older people, and then we're having 50 people come do an actual retest within 24 to 72 hours, so we can look at the stability of the measurement over time. And of course, we're thinking about, we've got questions and questionnaires to ask about acceptability and usability, and to make sure that this is actually a feasible option for us to use in our cohort. And then we're measuring health outcomes every 3 months for 1 year, so that we can also look at predictive validity as sort of another step down the line. So this has been an important sub-project among others that we're doing to help really inform, carefully how we can pivot our platform, but still make sure that our measurements are accurate. So in summary, we've gone through today some of the key strategies that we've used in MAC-M3 to pivot our research, and hopefully this illustrates sort of how, ties back to that continuum approach of pandemic research that we talked about earlier. So the key things we've done is switching to remote data collection and away from in-person assessments, so that we can move forward with our cohort as planned, changing our wear time intervals to 10 days to reflect the less frequent out-of-home trips, collection of additional mental health and mobility outcomes, including data on how people were doing before the pandemic. And of course, we didn't really talk about this, but it kind of goes without saying that we also need to collect information on the timing of the different public health restrictions that have happened over the last year, and that will continue to go on as we move forward with MAC-M3, and other COVID-related data, such as when people receive their vaccinations. And you heard Mary talk about anxiety related to that, and timing of that, and how that might affect people's mobility and mental health. And should anyone become ill from COVID. And this will be necessary in terms of both our analyses and for how we interpret our results. And I hope that it's become clear that our stakeholder, consulting with stakeholders, and in particular older adults, has been really critical to informing all of these pivots and others that we didn't have a chance to cover today.
Yeah, so in summary, we just want to thank our trainees, our partners, our colleagues, of course, in the School of Rehabilitation Science and beyond, in terms of the different disciplines that have been involved to help us carry this forward. And to Mary, of course, our older adult partners, amongst others who are, we're in discussions with them about their perspective of our project and that word that we've used, pivot, which has become also a popular word that's used in terms of being able to move forward. So again, thanks to our amazing staff at MIRA, at the MIRA Collaborative as well, that help us support research on aging and ultimately the health of all Canadians, older Canadians and beyond. So thanks very much. And we do have some questions and reflections. We've put them up here, but we are open. I understand Jennifer's been monitoring the chat as we've gone along in case there are questions, but to avoid those awkward Zoom silences, we put some food for thought up here to just perhaps reflect on in terms of your own pivoting with your own research project. But yeah. Jennifer.
There's a question. Thank you, Brenda, Marla, for a great presentation. There's a question in the chat box I just wanted to bring to your attention. So how confident are you in the validity of the mobility measures that are conducted virtually?
Well, Stu, that's something we're doing right now. So we're right in the middle of that study. I think some of them will probably do better than others. There's some, Timed Up and Go has been done virtually in other studies. There's just not a lot of good data and well-designed studies that have looked at this. And so and the other issue is really that you're limited in the home with what you can do. And so that's why we're looking at different versions, trying to, like, if we do a fast pace, does that help, discriminate a little bit more between people, especially people that are more higher functioning. So we're hopeful that we'll be able, from those 6 different measures that we're testing, that we'll be able to find at least a few that have good validity. But that's still in progress. So it's sort of an open question mark still in terms of which measures will make it into MAC-M3. I hope that answers your question. You can unmute yourself.
It's great. Thank you. It's one of those things that we're looking at as well, and it's hard to find. So with the exception, as you point out, of the Timed Up and Go, any data on validating these when the investigators aren't there in person. So great to hear, and look forward to seeing that. And congratulations on all of the data that you've generated. It's really outstanding.
Thanks. Yeah, I think one thing we want to think about, and that was one of the things I brought up, this idea that a lot of the research had been done with, the white upper and middle class, and that's not surprising, but also people with, having to come to the university, having to come to a place to participate in. And so we're hoping as well that we will, perhaps, have the real picture, so to speak, of people if we're doing this kind of thing in people's homes or in their, closer to their homes as well. If in fact things open up a little bit, to be able to do that in the pop-up at the library, for example. But need to think about that.
So there's another question in the chat box. Could you let us know a bit more about the types of mental health measures you used? Did you use any quality of life or general well-being measures?
Wes, do you want to start?
I think that's a really good question. There are so many measures available, and again, just thinking, what are the ones that are that we're able to do on the phone or online was also a consideration just when we were putting together, when I'm speaking about the survey now. So we have used the EQ5D as an example, and the elements of anxiety and depression within that, but it also has other questions in there that ask about quality of life as well. We do ask the sort of classic question as well in terms of how people rate their health, but that's not the same as a quality of life question. So I think the EQ5D is one. We do ask people, I think, about about their mood or their state of their mental health, again, a rating, and you know, ask them about their sense of worry about COVID-19. That was another question we asked as well. And then of course we say the impact of event scale, right, which is a validated measure that highlights various levels of distress. In fact, it also highlights people that are essentially at a post-traumatic stress level, and it doesn't diagnose, of course, and none of our measures diagnose. That's not what we're aiming to do here. But it does. We are able to track people across that 12-month cycle. But Marla, I don't know if you want to add to that.
Yeah, I mean, we also have a resilience. We have the brief resilience scale. We didn't end up, you know, and that's one of the things I think, because it did come out as something that was important in our survey. You know, I think that we will, in terms of what we're going to include in MACM3, we'll probably include some more comprehensive measures of anxiety and depression. We didn't, in piloting the survey, some of those longer measures didn't make the cut. But we do have the measures, as Brenda said, the EQ5D and impact of events, resilience scale, and then we have some single item questions about mood and worry about COVID and things like that.
Yeah.
Mm-hmm. But it would be great, Carol, to
thanks.
Yeah, it'd be great, Carol, to actually get your input on that as we move forward with MACM3.
Yeah, really happy to link up. But I think you've got some really good measures there, so that's great. Great talk, by the way.
Yeah, thank you, Carol. I'm really glad you were able to join us. We are excited to see you on the line in a nerdy way. One thing is that we don't know what people, the sample that we have, we started following them in the midst of a pandemic, after or in the midst of the first wave. So we actually don't know what people were like before, right? Other than, so in terms of their mobility, and that's a bit of a challenge. So, and it's the same with their mental health. We're only, asking these questions sort of in the midst, but nonetheless, it's been good to track.
Yeah, we do have questions about that, but obviously it's recall. They're based on a recall, so there's limitations.
Yeah. But we know, I think Dr. Parminder Raina, I'm not sure if he's on the line, but the Canadian Longitudinal Study on Aging has, launched a COVID-19 specific questionnaire with their sample that they were following all the way along, and have added questions as well. So they'll probably be able to perhaps comment on changes in mental health that they've seen as a result of the pandemic with their sample.
Yeah, Brenda, if I can add regarding the data for the CLSA that will be available in April about the COVID-19 questionnaire, so that can be viewed on our website then.
So there's a few more questions in the chat box. I'll read them out, but feel free to unmute yourself to follow up. So the first question listed here is, can you talk about to what extent you have achieved this diverse representation in your COVID impact study?
So I can start us off, Brenda, and you can tell me. This actually turned out, our sample is actually a little bit more diverse than some of our other studies have been. I think because we used census dissemination areas to identify areas where there were high proportions of older adults. And so we were just phoning people. And then we used a McMaster phone numbers to try and make sure that we got people to pick up the phone. And so we actually did, in terms of socioeconomic status for impact, we did achieve a more diverse sample, for example, than something you would see in the CLSA or originally with our Initiate study, because there was no requirement that people come in, and it was just a phone call, and it was just an hour-long interview. So we did pretty well on that. The only thing we didn't ask, we neglected to ask at the beginning, but we're asking now, is ethnicity. And so we added that question, and so that's one thing we haven't looked at yet.
We do have proportional representation in terms of gender as well. So that's state the obvious. But yeah, we're we're just getting responses on ethnicity, and that was something we had overlooked. But we do ask, to try to get at more specifics in terms of people's backgrounds. There is further questions about that. But
Great, thank you very much. I think it's an ongoing challenge for all research to think through that. So it's great that with those methods that you're able to tap into a more diverse population than sometimes we can. So, and thanks for a terrific presentation.
Like even with the interviews that we're doing, thanks Rebecca, and that's Rebecca Ganan, who people who don't know, who's amazing, from the School of Nursing and leading another, one of MIRA's big experiment projects in Bolden as well, looking at different regions in our beautiful city of Hamilton and trying to figure out how we can help people eat well and exercise as well. So another health promotion lens, but co-designing, right, with involving older adults as well in that initiative. But yeah, so thanks, Rebecca. I think our interviews as well, in terms of the people that we're sampling for our interviews, we've unfortunately we didn't have the question analyzed on ethnicity, but we have talked about the how people respond to socioeconomic status, and so thinking about that diversity when we're selecting people to be interviewed. We know that it's hard to generalize from interviews, but we're hoping to have some more insights around that notion of level of distress and other factors that may have impacted that.
I see a question on from Don Stevenson on functional reach test. Did we consider this as one of our remote measures? And and it's a great question, and I love test balance. So it was very, it was something that we did give a lot of thought to, how we could measure balance in the home, but do it safely. It's really, really tricky to do these tests, like your traditional standing on one leg test, or, the functional reach. Those measures we decided not to use. There wasn't data in the literature on them being used before in the home that we were able to identify. And just in terms of clinical experience, I've done a lot of balance testing in older adults, and these are measures that really require a spotter. If you're going to push someone to the point of these tests is that we challenge someone's balance to the extremes of their capability. And so when we're doing that, there's always a risk of falling. And so to be able to do that test in the home virtually, we just didn't feel like it would be a safe test to pilot. So that's why we didn't include the functional reach or other sort of more pure balance tests. And that, we're hoping that the timed up and go, especially the fast-paced timed up and go, might give us a little bit of balance information along with mobility information.
Great, thank you very much. That was helpful.
Thanks.
So there's another question in the chat box. Have you had a subset of participants who are unable to adapt to using tablets in their home? And moreover, do you foresee any biases that may emerge with this new protocol?
Yeah, I think one of our aims is to, and I think we have so much work to do in Canada, or in general, on the accessibility of technology. And so one of the ways that we're aiming to do that is to sort of, as Marla had alluded to during the presentation, is sort of have set up and ready, that participants don't necessarily have to have a lot of technology experience to be able to participate in our study. In fact, we don't want that to be a barrier for our participants to be able to participate. So the idea of having set up and ready is something that we're thinking about. We haven't launched it yet. All that to say, how are people receiving it? But that is going to be part of the pilot, is to understand the feasibility, what are the issues, and people can always in these studies actually, I don't want to do this, I can't do this, and stop participating at any point. That's their right. And so of course, we hope that's not the case, and we'll do our very best. And that's why we're doing usability testing right now. That's why it's so important we have feedback from older adults early in this process, older adults of all kinds of levels of technology as well to be able to understand if this is going to work or not. But Marla, do you want to add?
Yeah, we do. So in the validation study of the performance-based measures, we do have a technology usability questionnaire. So we will be looking at people's comfort with technology and how that affects their overall experience with doing the remote assessments. You know, in terms of biases, for sure there will be biases that are likely with this protocol. You know, I think that people that are willing to have a virtual assessment kit delivered to their home and to attempt that are probably going to be, you know, different people, for example, than we're willing to do our impact survey. And so, you know, looking for strategies to reach people that may be hesitant to sign up for something like this is something that, you know, we are going to have to really think about. And that's, you know, we're exploring partnerships with different community organizations to help us with this. But I think, you know, obviously it's not going to be perfect and there will be biases. And we're, you know, one thing that it's hard to predict the future, but when we are able to move back to in-person data collection, we may, and one of the things we're toying with is, are we going to have different arms of people that continue on remotely, and then we have an arm that come and do the in-person assessments. And that will allow us to sort of cross-validate different approaches and also to understand if different people are volunteering for different aspects of the study.
Yeah, I think one thing with you know, having this interdisciplinary team and partnering with older adults as well to get their perspective is that we all have disciplinary blind spots. That's what we call it, right? And so hopefully by sort of scaffolding on top of each other, so to speak, that we can sort of cover or at least acknowledge our limitations. And this certainly a volunteer bias, because at the end of the day, people need to give their permission to be in the study is certainly a limitation, but we are going to do our best, you know, working with partners like the library who understand how to serve underserved communities and have strategies for that. And that's something we really need to think about. And I know that Dr. Vrkljan and her colleagues, Dr. Stu Phillips on the Bolden Project, are also considering ways to involve people from different backgrounds. So it's a great question.
So we probably have time for one more question, if there's any or comment from anybody on the line. This is that awkward Zoom silence, Jennifer. Yeah. I have a hard time with it.
It's not that awkward. Calm down.
Wait, there is a question in the chat box. We at the JERA Center are conducting currently a study virtual frailty rehab at home during COVID, and we are providing iPads for those who do not have the device with internet facilities. So, interesting. More of a comment, but yeah.
Yeah, I think I've seen that on Twitter, that study, and it looks exciting. I mean, one thing we talked about was whether a tablet, we've talked to our older adults as to, and with Dr. Paula Gardner from Humanities, who's worked with older adults with different conditions, including early dementia, that actually sometimes a tablet is harder to set up to be able to be observed and those kind of things. So that's why we've actually considered using a laptop instead of a tablet approach, but that's something we're thinking. We're going to probably try a few things.
We're doing the tablet at the moment, but a tablet with a very user-friendly stand.
Yeah,
is what we landed on because we needed to preload internet, and that's not possible with laptops. But Surjat, it would be great to hear what you're doing in terms of assessments. Are you doing any of these assessments virtually with the iPad? Just out of curiosity. We did want to hear what other people were doing. Yeah.
Hi. So I have my coworker Karen too on the webinar right here. She'll be able to throw more light on it. But what we provide is we provide our participants with iPads for those who do not have the devices, and our study partner, that is the DST Physio Services, they are the ones who do the assessments virtually with these participants at the baseline and a 12-week follow-up. Okay. So we have the physical assessments done, like the sit to stand, and those are conducted by our blinded assessors at the Physio Services.
Great.
We will try to reach out to your team because we do need participants in this study. So those who have conducted the survey and who are, having loneliness. So we have a social arm and a multimodal arm to our study.
Mhm.
So it would be interesting to get in touch with your team.
Sure. Definitely the repeated chair stand seems to be the one that has the most evidence in terms of virtual administration along with the tug.
Yeah. And it's definitely interesting to, to adapt our study due to the COVID. Like we have another study called our fit joints with hip and knee replacement, which we kind of have adapted to the COVID related changes. Because it's virtual assessments and for those who have technology. Yeah.
Right. I mean, they're challenges, but it also has brought out all these opportunities to do things we would never have otherwise done.
Exactly.
Rebecca, I see that
it was a nice presentation, and we will reach out to you very shortly.
Thank you, Suja. Thank you.
Thank you.
Rebecca, you said you were doing a similar thing? Maybe, is she still there? Rebecca?
Hard to say. If you're working from home, right? What happens potentially in minutes? Sometimes.
We may have lost her.
Well, we have 2 minutes left in our webinar. I mean, one question I have for you both, or just to reflect on, is, you've done a lot of work collecting data to help inform, your cohort study. You're looking to the timing of vaccination and the public health measures, as COVID-related sort of data. Do you think a common set of COVID measures might emerge where, you talk about research being a continuum where sort of everyone's going to have to measure and analyze sort of the same set of COVID measures just to sort of make sense of their data? So it's just a question for you or something to think about.
I think that's a great question in terms of like a core outcome set for this measure. I mean, I think some of it will depend on your study design and purpose, what data you actually need. But I think we can definitely learn a lot from other studies. Like, this, as mentioned, the CLSA had launched a COVID study. And so we did try and keep some of our questions in line with what the Canadian Longitudinal Study on Aging was using, and then added some based on what we need. So I think maybe one thing that we're thinking about, we will publish a protocol paper, and we'll include our questions in the protocol paper, and perhaps there is a way to sort of make a recommendation for sort of the minimum data that you would want to collect at this time. But I do think it will be a bit study dependent.
Yeah, and you can see in our model that we have that, it's not a solid line, but it's a dotted line, right? That really what you're doing during COVID, post-COVID will probably lead in, right? To think about in terms of how we design our studies and to think about the measures that we're using now and to carry that forward in future research, I think is important.
Great, so I see. Yeah, thank you both. We're at 1 o'clock, so I thank everyone for joining the webinar. I thank our speakers, Marla and Brenda and Mary Mills, for speaking as well. And we'll be in touch, MIRA Collaborative, with future webinars in this series. And if you have any questions, feel free to reach out to myself or to Brenda and Marla directly for any additional questions or follow-up. So thank you, everybody.